or fibrillation, and if there is an early heartbeat, this is called premature contraction. So conductivity and automaticity has been already discussed in the introduction. So now, next slide, please. So now let's proceed with the 5 phases of action potential of the cardiac muscle. So in the phase 0, the sodium gates open and then the sodium rushes in. This is also called as a rapid depolarization. And then in the phase 1, the sodium channels become inactivated and then the potassium escape. This is also called as early repolarization. And then in the phase 2, the calcium channels open slowly, allowing calcium to enter, and then the potassium leaves. So so there is a balance kay lilip ang calcium and then the potassium leaves. So this is called a plateau phase. And then now let's proceed to the phase 3. Next slide, please. So in the phase 3, this is caused by gradual inactivation of calcium channels and continuous going out of calcium. So this is the final repolarization. And in the phase 4, this is the resting membrane potential or the resting phase. So everything starts from phase 4 and then ends at phase 4. The next slide, please. Okay, thank you. Now, let's define the hemodynamic. This is the physical study of flowing blood and where it flows. Next slide, please. Now, next slide. Okay, thank you. So this is the type of arrhythmias. So we have first the normal sinus rhythm. This is the rhythm of a healthy heart. In here, the electrical impulse from the sinus node is properly transmitted. So the values in the normal sinus rhythm are the normal ranges. So we have also the PACs or the premature atrial contractions. This is the premature heartbeats or the early heartbeats and occur in the upper chambers of the heart and do not typically cause damage to the heart and can also occur in individuals with no heart disease. Then next slide, please. So we have atrial fibrillation. So this is when the heart beats too slowly, too fast, and in irregular way. So that's why the rhythm is irregular. So this is the most common type of treated arrhythmia. Now let's proceed with the premature ventricular contraction or ventricular premature beats. This is the type of abnormal heartbeat. So you can see at the ECG. Now let's proceed with the last type of arrhythmia, which is the ventricular fibrillation. This is a dangerous type of arrhythmia because it beats too quickly and it is out of rhythm, as you can see in the ECG. Now let's proceed with the next slide, please. The anti-arrhythmic agents. Next slide, please. Okay, thank you. Now let's proceed with anti-arrhythmic agents. This is according to the Van Williams classification. So there are 4 classes of anti-arrhythmic based on their dominant mechanism of action. They act by blocking the membrane sodium, potassium, and calcium channels that was discussed in the phases. So now next slide, please. So this is the drug therapy across the lifespan. So let's just skip this. Kaya upato na discuss on drugs. Next slide, please. Next slide. Okay, thank you. Now let's proceed with the class 1 antiarrhythmics, which are the sodium channel blockers. This is a medication for ventricular tachycardias and atrial fibrillation. So we have 3 drugs where they're pharmacokinetic. So sodium channel blockers works mainly by blocking sodium channels in the inactivated state, and there will be inhibition of sodium channel and decreasing the heart rate, and then slows the conductivity. So there are 3 subclasses. So there are 3 subclasses, which are the class 1A, class 1B, and class 1C. So in the class 1A, there are 3 drugs. So with their pharmacokinetics, so the class 1A has moderate effect to sodium blockade. So let's remember that I made moderate effect. So there will be increased action potential duration and effective refractory period. So the effective refractory period is the period of time after an action potential has been triggered. So next slide, please. Now let's discuss the class 1B antiarrhythmic. Is the weak effect on the sodium channel blockade. And then it decreases the APD or action potential duration and ERP. So in the class 1C, in the class 1B, we have 2 drugs, which are the lidocaine and mixilotine. In the class 1C, this is the strong blocker. So class 1A has a moderate effect. The class 1B has weak effect, and in the class 1C has strong effect. So it has no effect on APD and ERP, and has 2 drugs, which are the plecainide and propafenone. Next slide, please. Then na-discuss na nila ako And then, okay, next slide, please. Okay, the contraindications and cautions. These are contraindicated in the presence of allergy, and then with bradycardia and heart block also, unless an artificial pacemaker is in place. So, caution should be used in patients with renal or hepatic dysfunction. Or this could interfere with the biotransformation and excretion of these drugs. Okay, next slide, please. Okay, so we have here central nervous system effects and GI tract symptoms, and then the cardiovascular effects includes the pro-arrhythmic effects. This leads to the development of arrhythmias. Okay, these drugs are also indicated in the treatment of potentially life-threatening ventricular arrhythmias and should not be used to treat other arrhythmias because of the risk of pro-arrhythmic effects. Next slide, please. Okay, clinically drug-to-drug interaction. So the risk increases if these drugs are combined with drugs that known to cause arrhythmias, or like that drug has a pro-arrhythmic effect, which is the digoxin. It will increase the probability of arrhythmias from occurring. Okay, now let's proceed with the next slide. I'm sorry, ibalik ka good section. Okay, sa clinically food-to-drug interaction, drug-to-food interaction di ay, kay ang quinidine requires a slightly acidic or normal state for excretion. So, the patient should not take food that alkalize the urine, such as citrus juices and milk products, kay mas mulid pa siya of quinidine levels and toxicity of the quinidine. And then we have here example also, if you take quinidine together with the grapefruit juice, can increase the side effects of quinidine such as nausea and vomiting and also dizziness. Next slide, please. Then we have now the class 2 antiarrhythmics, which are the beta blockers. They block the impulses that may cause an irregular heartbeat or rhythm, and then they interfere also in the hormonal influences on the heart cells. This is the management of premature ventricular contraction, so there will be decreased heart rate and decreased contractility. So contractility, this is the strength of contraction. So we have 3 drugs belongs to this class 2. So with their pharmacokinetics, next slide please. Okay. Now we have here the therapeutic actions indications. So this is a class 2 antiarrhythmics completely block beta receptor sites in the heart and kidneys. So there will be resulting in decreased heart rates and resulting na ganyan. So cardiac excitability, kaya mo ni siya characterized by sequential depolarization and repolarization. So depolarization, contraction, and then relaxation. And then next slide, please. Now we have the contraindications and caution. So contraindicated in the presence of bradycardia, which is the rate less than 45 beats per minute. And then a respiratory depression also. This could worsen due to the blockage. So so caution should be used in the patients with diabetes. One of the mitigation that should be avoided if a patient has diabetes are these type of antiarrhythmics. And also, it is reported that diabetes mellitus affects the beta blocker, the effectiveness of some beta blockers. And then these are the side effects. So in the respiratory effects, there is bronchospasm and dyspnea. So bronchospasm, this is hard to breathe, and then the dyspnea is shortness of breathing. Next slide, please. Okay, now we have here the drug-to-food interaction. So beta blockers can cause or exacerbate hypoglycemia. So this is, we all know that hypoglycemia is the condition in which your blood or the blood glucose level is lower than normal. So in some individuals kay usahay ma-worsen ang present na hypoglycemic sa ilaha, or sometimes can delay the recovery. Next slide, please. So after the class 2 antiarrhythmics, here we have the class 3 antiarrhythmics, which are the potassium channel blockers. They act by prolonging the duration of action potential duration and effective refractory period, which is very helpful at preventing those arrhythmias caused by reentry, particularly reentrant rhythms. So reentrant rhythms kaya mo ni siya ang abnormal cardiac rhythm. So we have four drugs belong in here. So we have Amiodarone, Dofetilide, Sotalol, and Ibutylide. Next slide, please. So we have here the contraindications and caution. So there is no contraindication sa class 3. So ang Ibutylide and Dofetilide should not be used in the presence of AV block kay ma-worsen pa siya sa drug. Okay. And then sa adverse effects, so na siya vomiting, GI distress, weakness, and dizziness. And then here we have Amiodarone. So Amiodarone has been associated with fatal liver toxicity if it's in long-term use. So there is also ocular abnormalities. This is optic neuropathy, and wherein the Amiodarone can cause permanent visual changes. And then cardiac arrhythmias development, so could worsen or develop arrhythmias. Next slide, please. Now we have the drug-to-drug for food interaction, so quinidine. So we have serious effects when combined with quinidine because quinidine blocks other potassium channels, and then sometimes quinidine have occasional or unpredictable development of torsade de pointe. This is an abnormal rhythm that can cause sudden cardiac death. So with digoxin, increased digoxin toxicity. And then now let's proceed to the next slide. So after the class 3 antiarrhythmics, here we have the class 4 antiarrhythmics, which are the calcium channel blockers. So this is the medication for supraventricular tachycardia and atrial fibrillation. So calcium channel blockers prevents calcium from entering the cells of the heart and arteries. So because the calcium may have an abnormal movement and may affect directly or impair the contraction and the relaxation of the heart. Manang i-block siya. That's why, okay, now we have here, so first, so we all know that the calcium channel blockers have two subtypes, which are the dihydropyridines and non-dihydropyridines. So only the non-dihydropyridines have anti-arrhythmic properties. That's why ang two drugs ra ang naadiri, which are the diltiazem and verapamil, they belong to non-dihydropyridines. Next slide, please. So, class 4 antiarrhythmics delay the phases 1 and 2. Ang phases 1, kay mo ni siya ang potassium, wherein ang potassium mugawas, and then the phase 2 kay ang potassium mugawas, and then ang calcium musulod. Kaya ang delay. And then next, we have contraindication. So, these drugs are contraindicated with known allergy to any calcium channel blocker. And then caution should be used in cases of idiopathic hypertrophic subaortic stenosis. Paano siya? Kanang mo ni siya ang wherein a case na ang left ventricle is hypertrophied or there is an increased size sa both sides, and then the cavity is really small. So there will be possible aggravation of the outflow tract obstruction. Okay, next slide, please. Okay, these are the adverse effect and clinically important drug-to-drug interaction. Nara dira explanation daan. Next slide, please. Okay, now let's have the other antiarrhythmics, which are the adenosine, digoxin, and Adrenederon. First, let's tackle about the adenosine. Next slide, please. So adenosine slows conduction time through the AV node and can interrupt re-entry pathways through the AV node also. It suppresses automaticity, and the biggest benefit ani na drug is this is relatively non-toxic with most common side effects like chest pain and hypotension. So it has very short duration of action also, and the heart transplant recipient is very sensitive aning a drug, so the dose must be reduced. And then we have here the digoxin. This is slows calcium leaving the cell and prolonging the action potential and slowing the conduction heart rate. So there will be decreased heart rate and then increased duration of effective refractory period. Next slide, please. Okay, so Now we have the last other antiarrhythmics, which is the Adrenederon. So Adrenederon works by blocking potassium, sodium, and calcium channels and exhibit anti-androgenic properties. So anti-androgenic properties mo ni siya ang katong where ang heart kay mo beats lower and then with less force and then normal ayahang relaxation. So this is a banishment for atrial fibrillation and atrial flutter. So this will reduce the cardiovascular hospitalizations in the case of atrial fibrillation patients. And next slide, please. So this is the nursing consideration, and then we have here the nursing diagnosis, explainable ra siya kayo. Next slide, please. And then the planning implementation. Next slide. And then we have here the evaluation. And that ends my report. Thank you.
A pleasant morning to all of us. By the way, I am Christine Grace I. Bermudo, one of the reporters from the Unit 8. So now we will be discussing the Chapter 46, which focuses on the anti-anginal agents. So let's define first what are anti-anginal agents. Next slide, please. Okay, so anti-anginal drugs are used to assist restore the proper supply and demand ratio in myocardial oxygen transport. So the most prevalent cause of an imbalance in this ratio, which manifests as discomfort, is the coronary artery disease or CAD. So when the coronary veins are already severely damaged and having problems maintaining the blood flow to the heart muscle, the anti-anginal drugs are utilized to prevent myocardial cell death. So here are the drugs that are considered as anti-anginal agents, which includes the following. So this includes the nitrates, the beta blockers or the beta-adrenergic blockers, the calcium channel blockers, and lastly, the piperazine acetamide. So next slide, please. So the myocardium, a cardiac muscle tissue, requires a steady flow of blood in order to obtain the oxygen and nutrients it requires to keep pumping. So the myocardium gets all of its blood from two coronary arteries that emerge at the base of the aorta from the sinuses of Valsalva. The capillaries that carry oxygen to cardiac muscle fibers are formed as these arteries divide and subdivide. Okay, next slide, please. So the heart muscle, unlike other tissues in the body, receives its blood supply during the diastole, when it is at rest. So this is significant because as the heart muscle contracts, it tightens and closes the blood arteries, preventing them from receiving blood during systole. So when all other tissues receive new blood, when the heart is at rest, the openings in the sinuses of Valsalva, which are the start of the coronary arteries, are positioned so that they can be filled when blood flows back against the aortic valve. So the pulse pressure, the pressure of the blood column falling back against the closed aortic valve, is what fills these veins. So the heart has just finished contracting and drawing energy and oxygen from the environment. So local vasodilation occurs as a result of the acid and carbon dioxide buildup in the muscle, allowing blood to flow easily via the coronary arteries and into the muscles. Next slide, please. So now we will be defining the coronary artery disease. So the lumens of the blood arteries narrow in the coronary artery disease, preventing the blood from flowing easily to the muscle cells. The growth of atheromas or fatty tumors in the intima of the vessels causes the narrowing of the vessels, which is known as the atherosclerosis. So in figure 46.1a, so the intimal lining of the vasculature is damaged by these deposits, which attract platelets and immunological factors, producing swelling and deformation of a bigger deposit. So the size of the vessel is drastically reduced as a result of these deposits over time. So while deposits in the intima narrow the channel, it also loses its natural suppleness, making it unable to respond to the typical stimuli that cause it to expand or contract to satisfy the needs of the tissues. So what we are seeing here is the figure 46.1 that is provided in the book. So this is a visual representation of an atherosclerosis. So figure A, which is the image in the left side, is this schematic illustration of atheromatous plaque. So the thick yellow substance there is the plaque that makes the vessels narrow, which prevents the blood to flow easily and to the muscles. While figure B, which is the image in the right side, is the thrombosis of atherosclerotic plaque. It may partially or completely occlude the lumen of the vessel. Okay, next slide, please. So now let's proceed to angina pectoris. So atherosclerosis patients face a classic supply and demand conundrum. So the heart may function normally until it is forced to beat faster or harder due to increased exercise or other pressures. So when this happens, the heart should normally encourage the veins to give more blood, but the restricted vessels are unable to respond and cannot provide the blood required by the working heart. So the cardiac muscles becomes hypoxic, which means the heart muscle would experience inadequate levels of oxygen. So now let's define the angina pectoris. So this literally means suffocation of the chest, and it is the result of an imbalance between oxygen supply and demand. So angina is the pain that the body experiences when there is a lack of oxygen in the heart muscle. Although the heart muscle lacks pain fibers, ischemic myocardial cells release a chemical called the substance P, which causes pain anywhere substance P interacts with the pain receptor. So many people experience discomfort in the chest, while others experience pain in the left arm, and still others experience pain in the jaw and teeth. Okay, so now let's go on to the different types of angina. So stopping what you're doing and waiting for the pain to go gone or to go away is the typical response to this type of pain. Stopping activity may bring the supply and demand for blood back into the balance in cases with mild restrictions in blood flow through arteries. So this is referred to as the stable angina. So in chronic angina, the heart muscle is unharmed and the fundamental reflexes that surround pain restore the blood flow to the heart muscle. This procedure can continue indefinitely without causing a myocardial infarction or MI. Then chronic angina is a condition in which a person's activities and quality of life are significantly limited. Okay, next slide please. So next type of angina is the unstable angina or pre-infarction angina. Even while the patient is at rest, if the narrowing of the coronary arteries worsen, the heart may undergo periods of ischemia, which is a condition in which the blood flow is restricted or reduced in a part of the body. So even if no damage to the heart muscle occurs, the person is at danger of a complete blockage of the blood supply to the heart muscle. So if the heart is forced to work harder or the oxygen demand rises. Then the next one is the Prinzmetal angina. So it is a unique type of angina in that it appears to be caused by blood vessel spasms rather than just vessel narrowing. So this kind of angina manifests itself as angina at rest, generally at the same time each day and with a change in the electrocardiogram or ECG pattern. Okay, next slide please. So now we will proceed to the acute myocardial infarction. So if a coronary vessel gets entirely blocked and unable to carry blood to the heart muscle, the muscle that relies on it for oxygen becomes ischemic and then necrotic. Then myocardial infarction happens, or myocardial infarction is also known as the heart attack. So it is possible that the pain associated with this incident will be intense. There may also be nausea and significant sympathetic stress reaction. Arrhythmias can occur in surrounding ischemia and irritable tissue after a myocardial infarction. So this is a significant risk. So the majority of MI-related deaths are caused by fatal arrhythmias. So if the heart muscle is given a chance to recover, scar tissue will grow in the necrotic area within 6 to 10 weeks, and the muscle will compensate for the injury. However, if the muscle is destroyed across a broad region, it may not be able to compensate for the loss, resulting in heart failure and even cardiogenic shock. So these disorders can be fatal or significantly impair a person's ability to function due to a weaker heart muscle. Okay, next slide, please. So when the heart is sufficient, anti-anginal drug or insufficient rather, anti-anginal drugs are used to help restore the proper supply and demand ratio in oxygen transport to the heart. So these medications can enhance blood flow to the heart muscle in one of two ways. One is via the dilation of the blood vessels, raising the oxygen supply, and two, by lowering the heart's workload or decreasing the demand for oxygen. Okay, next slide, please. So there are several factors that influence the demand for oxygen by the heart muscle. So these includes the heart rate, the preload, afterload, and the stretch on the ventricle. So for the heart rate, this refers to a quicker heart rate demands more energy. So in preload, or also known as the blood volume, the more blood returns to the heart, the more pumping is necessary to empty it, which requires more energy. Let's proceed to the afterload, or the blood pressure. So the more pressure the heart has to pump, the more energy it is requiring. Next, and the last one is the strain on the ventricle, or the stretch in the ventricle. So the farther apart the actin and myosin fibers are, the more energy is used. So when they react and slide or contract. Okay, next slide, please. So angina is treated with nitrates, beta-adrenergic blockers, and calcium channel blockers. Piperazine acetamides, a newer class of medicines, are now accessible to treat persistent angina. So this type of drug's mechanism of action is unknown. However, it reduces the myocardial workload without lowering the heart rate or blood pressure. Okay, next slide, please. So figure 46.2 shows us the interaction between the anti-anginal agents along with the factors that influence the myocardial oxygen demand. So when anti-anginal agents, namely the nitrates, the beta blockers, the calcium channel blockers, react with the factors, namely the heart rate, the blood volume or the preload, the blood pressure or the afterload, the left ventricle muscle size, and the muscle contractility. So these will all lead to myocardial oxygen consumption. Okay, next slide, please. Now let's proceed to table 46.1, which are the drugs in focus in anti-anginal agents, starting with the nitrates. So this includes the amyl nitrate, the azoxystrobide dinitrate, the azoxystrobide mononitrate, and the nitroglycerin. Then for the beta blockers, it includes the metoprolol, the nadolol, and propanolol. Now for the calcium channel blockers, next slide please. Then for the calcium channel blockers, it includes the amlodipine, the delshazam, nicardipine, and verapamil. Then lastly, for the piperazine acetamide, it includes the drug ranolazine. So these drugs will be discussed further later on. So now let's move on to the drug therapy across the lifespan. So for the drug therapy across the lifespan, you can just read on this on the book. So we will just skip this one. Next slide, please. Okay. So now let's proceed to the first group of drugs under the anti-anginal agents, which is the nitrates. So nitrates are medications that relax and depress the muscular tone by acting direct on the smooth muscle. So these medications have a direct impact, thus they have no effect on nerve or other activities, and the response is usually quite quick or fast. So azoxystrobide dinitrate or azoxystrobide rather, azoxystrobide mononitrate or monocat, and the nitroglycerin, nitrobid, nitrostat, and others are all nitrates. So for its mechanism of action, the nitrates relax and dilate or widen veins, arteries, and capillaries, allowing increased or more blood flow through the vessels and lowering systemic blood pressure because of a drop in resistance. Okay, next slide, please. Now let's move on to the drug effects of nitrates. So because coronary artery stiffening and lack of responsiveness are caused by coronary artery disease, nitrates are unlikely to increase blood flow via these arteries. They do, however, improve blood flow in healthy coronary arteries. So as a result, blood flow via any healthy veins in the heart increases, potentially assisting the heart in compensating. Then the predominant effect of nitrates, on the other hand, appears to be related to the resulting drop
Okay,
in blood.
go direct to the point. So, what is now the effect of nitrates on the blood vessel?
So the effect of nitrates in the blood vessels, docs, is to increase the blood flow in the healthy coronary.
Diretso, what is its effect on the blood vessel? Wala
It
dagang
does
pangyawid. Diretso lang.
it,
Dilation o insakto kahalin, dilation, period.
thank
Never
you.
mind the very specifics of how it causes vasodilation. Mabuang mo ana, dilihan mo pharmacy students. So, ang pharmacy students gani duha ka subjects nila ni inyuha usara unya naapa mo yung mga nursing implication. So, dili ninyo madala na tanan. So, go direct to the point lang. Effect niya sa imong blood vessel is dilation. Okay, your problem now is angina pectoris. Okay, you know that angina pectoris, ang problem niya is there is a narrowing of the blood vessel, coronary blood vessel, meaning blood vessel sa iyong heart. If there is narrowing of the blood vessel sa inyong heart, kung sa may mitabo, less ang chances of, less ang perfusion of the heart. Kung sa may ganit ng perfusion, delivery of blood to the heart. Moingon mo nga, napuno nag-blood ng heart, di adun mo agi ng blood. Yes, the blood, the problem here is, the blood that goes into the chambers of the heart does not supply the heart. Remember this, ha? The blood that goes into the chambers of the heart does not supply the heart. Mauna nga, during the active contraction, during systole, the heart muscle contracts. So, kung sa may tabo sa blood vessel, gani kung mo contract gani ang muscle, maipit ang blood vessel. So, there will be no supply of blood to the heart during contraction or during systole. It is only during diastole when the heart muscles relaxes, mo open up po din yung coronary blood vessels. What are coronary blood vessels? These are blood vessels supplying the heart. Coronary means heart. So it's only during diastole that the heart muscles are supplied with the blood. Those blood that goes into the chambers does not supply the heart. Okay? So now, unsa may dining excuse me. Kaning angina pectoris is just ang mechanism sa mga angina pectoris is the imbalance between the supply and demand of the blood to the heart. The heart, if the heart needs more blood, your supply is the same, dili niya ma-improve ang supply, so it causes pain, anginal pain, or what you call the chest pain, experienced with angina pectoris patients. Okay, if the demand is increased, you should also increase the demand. So again, ang pathophysiology niya, the mechanism of development of angina pectoris is the imbalance between the supply and demand for blood. Okay, so what will you do now? You have only two choices. Is either when the demand increases, you increase the supply, or you decrease the demand so that the same supply can hold true. Again, since the imbalance between the supply and demand is either you increase the supply if warranted, if kinahanglanon ninyo, you have to increase the supply, or you have to decrease the demand. Kay kung dili mo maka-increase sa supply, you just have to decrease the demand. Para kay inyong supply mo or mangyapon. So you just decrease the demand. So those are only the two ways. Predominantly, those are the major ways to treat your angina pectoris. Angina pectoris is just, again, it's either narrowing due to obstruction of the coronary blood vessels. When angina pectoris is more pronounced, kung complete na yun obstruction, it will not be angina na, it will be myocardial infarction na. Okay. Ischemia is another term for decrease in the supply due to probably spasm of the blood vessel or due to cholesterol plaques or any obstruction that causes the impedance of your blood supply to the heart. Okay, so mauna ha. So again, what is the most common cause of your angina pectoris? It's simple cholesterol plaque. Ang atong heart failure, when we discuss that to you, ang cause niya, plaque lang gihapon. So be sure to inhibit yourself from eating too much of those sugars and cholesterol. Parang at your age, dili mo develop og plaque. Now, what is the common cause of angina or heart failure, or is what do you call this? Obstruction sa even heart attack, myocardial infarction. What is the most common cause for the younger generation? Magkasabot ka sa mga gulang-gulang na kay tungod sa kadugay nilang kinaon og mga sugar o mga tambok, etc. Di will come a time nga mo accumulate yun na sila. Of course, tungod sa kadugay, tungod silang age. How about the younger generation? Kamo, bago-bago pa man magasig kaon og to the max ana. So, what is the most common cause sa mga younger generation? Mga 20s, it's spasm. Mokalitra og spasm yung coronary blood vessel. Of course, you already know what is spasm. Mo constrict og maayo ang blood vessel. Coronary vascular spasm. Now, sa hinungdanan, we don't know ngano magspasm usahay ng mga coronary blood vessel. We don't know what really causes the spasm. That causes the myocardial infarction in the young. Okay? So, we have a lot of, there are a lot of names for angina, whatever the cause. We have you don't have to know the names, ha? Kaya anyway, dili man ni ato ang problema sa pagkakaroon. We have what you call Prince Metals angina, you have variant angina, daghan na sila. Now, those, some of those are caused by spasm lang, dili mo ang atherosclerosis. Okay? So, again, your vasodilators will solve which problem as a cause of angina pectoris? Vasodilator, reporter. Kung sa ma-solve sa vasodilators? Hoy, intawon, reporter. Kinsay reporter?
Doc.
Bermudo?
Yes, sir.
Okay. I-explain na nako ang development sa angina pectoris. I-explain na nako what is the pathophysiology or the mechanism of development of angina pectoris. So now the question is very simple. When you give vasodilator, what problem is solved there in the development of angina pectoris?
The narrowing of the vessels, sir.
Unsa ganito ato ang problema, Inday. Yes, you are correct. It is the narrowing of the blood vessel. But in the development, what did I tell you? It's the increase in the demand and decrease in supply. Which means, unsa may gisolve ana niya, because those are the two problems. Increase yung demand, ni decrease yung supply. Because there's an imbalance between the supply and demand. So again, which of the two is solved by your vasodilators? Uy, kasimple lagi kayo sa question, Inday. Mamili lagi ka sa duha. Gamit-gamit po taon sa auto panagsa lang yung taon.
The demand for oxygen, Doc.
Why? The question is, why will it solve the problem of demand sa oxygen? This is the problem when you are used to memorization. This is the biggest problem. You don't use your brain. Memorize sa dayon. You are not using your brain when you memorize. Ano man, monotonous kayo na magsige memorize. I am making these things easier for you para di mo madugay sig memorize. Nga naman, nga mo decrease man ang demand kung mohatag ang vasodilator.
Because it would widen the vessels, Doc.
So if it widens the blood vessel, does it decrease the demand? Pananglitan, Inday, na kay gripo sa tubig, imong gipagamay ang imuhang agianan sa gripo. unsa may imong gibuhat? Gipagamay nimo ang supply nimo or gipadako nimo ang agi ang supply nimo? 1 plus 1 na na. Gipadaghan nimong agis tubig o gipagamay nimong agis tubig? Kung imong gipagamay ang agianan.
Ipagamay ang nagtanan, Dok.
Gipagamay ang agi, correct. So kung imong padak-an ang agi sa agianan sa tubig, unsa may metabo? Mudaghan ang tubig nga mugawas o mugamay ang tubig nga mugawas?
Dok.
Ha?
Mudaghan naman.
Mudaghan. The same thing happens with your blood vessel. So when you said vasodilation will decrease the demand, it's entirely 1,000,000% wrong. Ako nang gihatag ang basis nimo, gi-relate na to sa tubig because it would be the same story. So which means giving vasodilators or increasing the lumen of your blood vessel will increase, of course, the supply of your blood. It does not decrease the demand. Kinsa gi-demand gani og blood nimo? It is your heart that demands the blood. So what will you do to decrease the demand from the heart? Imo ipahinay og beat ang heart. If you decrease the beating of the heart, that will decrease the demand. Because the more the heart increases its muscular contraction, the greater will be its demand for the blood to supply the nutrients for the muscle contraction. Did you understand? Are there any questions regarding such mechanism for everybody?
No, Doc.
None. This is your only chance to ask. So, wala man ka, we will continue. We have discussed vasodilators already, we don't have to deal more on this. Muna ha, ang Angina Pectorius is just the discrepancy between the demand and the supply. Okay, continue, next slide.
Okay, thank you so much, Doc.
Unsa na tanan chapter unsa na ni? Chapter
46, Doc.
Chapter 46. Okay, continue.
Okay, Doc. So now let's move to the pharmacokinetics of nitrate. So a sublingual tablet, translingual
Okay,
spray,
these are the available preparations na sublingual, na ay lingual, okay, IV, transdermal patch. Kana transdermal patch, mura na siya katubitaw sa lumpas that contains nitroglycerin na imong ipapilit ra. Again, what is the mechanism of action of nitroglycerin? Again, your nitrates, mechanism of action of nitrates.
vasodilation, Doc.
Mechanism of action in vasodilation is the effect.
And dilates the
Kusga.
white vein. It relaxes and dilates the
That is the effect lagi. That is dilation, the same animal as dilation. So, unsa may imong mechanism of action? Vasodilation is not mechanism of action. Vasodilation is the effect. How does it cause vasodilation?
by decreasing the demand
By?
by decreasing the oxygen demand of the heart, Doc.
Nahala. Nitroglycerin, the mechanism of action is it is a nitric oxide donor. Again, the mechanism of action is nitric oxide donor. Nga naman di ay, what will the nitric oxide do? Nitric oxide, your NO, will increase your cyclic GMP. Okay? Production of your soluble guanyl cyclase, ang imuhang cyclic GMP, will be increased. Okay? So, increase ganin mong CGMP, we have discussed this already. What is the effect of cyclic GMP? The cyclic GMP will promote vasodilation. So what is again the mechanism of action of nitric oxide of your nitroglycerin? It is a nitric oxide donor. The same is true with your isosorbide mononitrate and your isosorbide dinitrate. Okay, next slide.
Okay, so let's jump up to the contraindications of nitrate. So to avoid hypersensitive reaction, nitrate is not recommended if you have a nitrate allergy, and these medications are also harmful if you have any of the following conditions, such as pregnancy or lactation, because of potential adverse effects on the increase in cardiac output could be harmful in addition to
Okay, adverse effects, you just have to read on that. Again, I told you, read on that. Okay, next.
discuss the clinically important drug-to-drug interaction.
Okay, this is very important. Tanawan ni ang imuha nga reaction with your sildenafil. Okay. By the way, it is your tadalafil that has an increase in your duration of action, not sildenafil. Sildenafil is your Viagra. Your tadalafil is katong mga Cialis ninyo. Okay? Remember that, ha? Tanawa, nitrates, you should not use it. Now, not, should not. Tanawa na, should not. Okay. Isige na ito nagbalik-balik, ha? When we discuss about reproductive. So, okay. Read on the nursing consideration. Next slide. Okay, read on those. Okay, beta blockers. We also discussed beta blockers already. So, unsa gani ang imuhang effect sa inyong beta blocker? This is already the mechanism of action, ha? Beta blocker is already the mechanism of action, or beta adrenergic blocker. So, what is its effect in mga beta blocker, Inday? Ha? Digyo ko, kadungog ni mo kay kachapi kay ka. Unsa effect niya?
Wait lang, happy ko, Doc.
Sige, unsa effect niya? Diretso.
Reduction in the heart excitability, Doc. And a reduction in the cardiac output.
Go sa direct ng effect niya lang. Go direct. Ayaw nang nalagang mga pasikot-sikot. There is only one word lang.
Reduction in cardiac oxygen consumption.
Why? Why will it be reduced in mong cardiac output? Sige. I will go with your stream of thought. Sige. Kaya ganahan makagtuyok-tuyok. Sige, tuyok-tuyok ko na to. Why? How does it decrease your cardiac output? Sige. By... Hello, are you still there?
Yes, Doc.
Okay.
It's
Slowing down the heart rate or bradycardia. Simple. Sumaura na iyang effect sa imong beta blocker. Decrease ang heart rate. So, mauna iyang effect niya. Mechanism of action is beta blocker. Effect niya, decrease ang heart rate. Now, my question is, which of the two parameters in the development of your Angina Pectorius is treated with your beta blocker?
is that again, Doc? Medyo choppy pa sa ako ang endocrine ako.
Okay. Sa uban ng mga listeners, Shopee ko, dili. Basig ako ang signal mo'y problema or iyang signal.
Dili ra, Doc.
Dili ra ko, Shopee. So, it's not my signal that is the problem. It's your problem. So, can anybody answer this? Beta blocker. What parameter in the development of Angina Pectorius does it solve? If your vasodilators will solve the problem on supply, yes, you are correct, Miss Folio. It is the demand. Why? Because if you decrease the contraction of the heart, decrease the rate of contraction, you are decreasing its demand for blood. Di naman yung may patrabaho maayo. So whatever are the causes of the disease, you have to solve the cause. Huh? You have to treat the cause. Muna atuag yung aim. Atong i-treat ang cause sa disease. Since the problem with Angina Pectorius is the supply and the demand, we have to solve the supply and the demand. So, muna itong ginasolve karon. Parang hindi mo magdaghan pang diyawit. Maura gina. Next slide. You already know the beta blockers. Kumana na to sa ito ang CNS nga problem nga. Di ba? We discussed that already sa ito ang neurologic drugs. Yes or no? Yes. So, next slide. Okay, you also know the side effects already. So, next slide. Balik-balik na ni balik-balik. Sige. Balik-balik. Kumana na. Sige, next. At least read on those, sir. Read on those. Now, the next will be your calcium channel blocker. Again, that is already the mechanism of action. Calcium channel blocker. Diba kibalo naman mo nga ang calcium will cause contraction? Sige. Sige, ikaw sa kuya isa rin. Kaya sabak pa dali sa kuha. Ikaw kung may isa pa dayon. Yeah.
Okay, Doc. So now let's proceed to the next group of drug under the anti-anginal agents, the calcium channel blockers. So amlodipine, dalshazam, nicardipine, nifedipine, and verapamil are calcium channel blockers. So for its mechanism of action, calcium channel blockers prevent calcium ions from moving across the membranes of cardiac and arterial muscle cells, causing the action potential to change and muscle contraction to stop. Okay, now moving on to the drug effects. The effect includes the following: the smooth muscle tone is lost, vasodilation occurs, and peripheral resistance is reduced. So as a result, preload and afterload are reduced, resulting in a reduction in cardiac workload and oxygen consumption. Then calcium channel blockers are used to
Okay, so again, to make it short, what problem is solved? Sa inyo ang Angina Pectorius, ha? What problem is Angina Pectorius solved with your calcium channel blocker?
muscle contraction.
Wala. Di ko ni siya kasabot yung taon. Okay, katurag yung duha akong gipangutana, inday. Maurag ito pilihan ni mo. Kung saan problemahan niya is solved.
It reduces the cardiac oxygen consumption, Doc.
Okay. Sige, dawaton na to na siya kay ganahan man gyud kag imong kagulingon. Sige, go. Okay, you are correct. In short, sa ako nagisulti, parang libog, it decreases the demand. Okay. Sige, padayon.
Okay, so
I am discussing this drug in relation to your disease nga gitreat. Pandi mo maglibog nga ano kung gigamit ani. So, maura na siya. Para di na mo maglibog. Sige, next slide.
next slide, please.
Nakatulog si Christian Tinapaw. Either nakatulog o nikaging. Wala, nikaging di nga signal. Okay, so we will wait. Kinsay ga discuss itong chapter 45 gani, if I may ask.
Ako, Doc.
Okay, Miss Moreno Lacalle.
Yes, Doc.
Now, okay. So what are the drugs that are usually used in cases of your arrhythmia? Classification lang, ha? I'm talking about classification of drugs.
Katong mga classes, Doc.
Okay, sa my classes.
Katong class 1 to class 4.
Okay. Now, please take note, when you use your anti-arrhythmic drugs, you just have to take note of those classification. Nothing more. Again, I am telling you, I am informing you how to study the antiarrhythmic drug. Kato lang siya. Just take note of those classification, nothing more. Because in those classification, naa naman dito ang inyong mechanism of action. So, di na ninyo problema ng mechanism of action. Kailangan dito. It is classified according to its mechanism of action. So, inanara pagsari itong antiarrhythmic para sa iyon lang. Then now, ang imong pong anti-anginal drug, you just base it on the two problems, the parameters in the development of angina pectoris. Okay? So, we'll make it simpler for you. So, okay, sige na, next. Continue na in the Miss Bermudo. So, go next slide. Just read on the adverse effects. Balik-balik na siya, balik-balik. Okay, if I may ask again, why is a headache so prominent when you use your vasodilators? Kita gina may headache. Oh. Kung vasodilator.
Or dilating, Doc, in headache.
Because it is the vasodilation that causes the headache. Muna siya mechanism mo ng headache, vasodilation. Now, bisan tuog the most common reason nganong ba ang mag-headache is vasodilation, there are also some cases wherein extreme or increase in constriction or vasospasm will cause headache also. In the same way as when you drink coffee, it causes vasoconstriction, ano? So it treats your headache. But there are also cases na ang coffee makakause og headache. Na, so mo na gusto na kayo pasabot. But under general circumstances, of course, it is the vasodilation that causes the headache. Sige. Continue. Skip that. Next. Okay, so what is the mechanism of action of this? Not understood. Since it is not understood, ayaw na naguna-una. Go to the next.
Pharmacokinetics, ranolazine comes in an ER tablet form for oral administration. It is quickly
Next.
absorbed with peak levels.
Basahan na siya. Okay.
Now, for the adverse effects of the drug, dizziness, headache, nausea, and constipation are the most commonly experienced adverse effects. Then, for the drug-to-drug interactions, the ketoconazole, the dalshazam, verapamil, macrolide antibiotics, and HIV protein inhibitors might produce drug-to-drug interactions, and these combinations should be avoided since ranolazine.
Take note of that. They should not be used. Why? Because these are vasodilators, imong verapamil, diltiazem, etc. You use the vasodilator with another vasodilator. Kung saan may tabuan na, mag-hypotension na mo. Okay, so dili maing gamiton ng tagura, dublihon yun yan. Okay, sige, next.
So, that's my report, Doc.
Okay, so that is the end of chapter 46. Dili siya kay balong motubag og yes og no.
Yes, Doc. I'm sorry, Doc.
So, good. 47 na ta. These are really very, very, very short topics. Don't make it complicated. I did not deal more on the nursing implication because it is for you to read. Self-explanatory ramang God ng mga nursing implication. Very self-explanatory. Ang ato lang i-discuss dere is ang kanalang mga mechanisms of the drugs and the drugs good mismo. And why is it used? Again, I am more on how and the why. Parang dili na mo magsige og memorize. Nga na gud gigamit ani niya. Na we go to lipid-lowering agents. Okay, what does it mean? It lowers your fat content. Your lipid is your fat. Not the fat nga kanang sa inyong katambo ka, dili na siya may gilower ani. It is the fat sa inyong blood ang gilower niya. Dili ang fat sa inyong beneath your skin. Kung pwede palang unta na palay makapalower anang fat sa beneath sa tuwang skin, baling sa daha unta. Daghan natang manggamit ani. Wala lang. Sige, unless magpa-liposuction ka. Sige. Or magpatamitak. Continue, Day. Proceed with your report. Who will be reporting this?
Ako, Doc. Good morning, Doc. Okay, so I'll now start, Doc.
Okay, loud and clear again ka, Inday. Miss Sabanal.
Sige, thank you, Doc. So I'll now start, Doc. So good morning, everyone. Good morning, Doc. So now let us move on to chapter 47, which is the lipid-lowering agent. So in the previous chapter, we have already discussed drugs that help prevent myocardial cell death when the coronary vessels are already damaged and they're already having trouble maintaining the blood flow to the heart muscle. In this chapter, we will be talking about those drugs that prevent the blocking of the coronary arteries before they become narrowed and before they cause damage. So, specifically from the title itself, we will talk about those drugs that will control or that will lower down the lipid levels in our body. So, next slide, please. So before we dig deep into the discussion, let us first unlock some key terms that will be discussed in this chapter. So we have our anti-hyperlipidemic agents. Of course, these are those drugs that lower the lipid levels in our blood. Bile acids, this act as emulsifiers, or they act like detergents that break down the fats in our small intestine. And then we have here our cholesterol. These are necessary components of human cells because it is part of our steroid hormones and, of course, of our cell membrane. So it is produced and processed in our liver, and it is stored as bile until stimulus causes the gallbladder to contract and send bile into the duodenum via the common bile duct. So we have our chylomicron. It is the carrier for our lipids in the bloodstream, and it consists of proteins, lipids, cholesterol, and so forth. Next term, we have endocannabinoids. So these are endogenous substances that activate the nervous system receptors that are important in the regulation of appetite, food intake, and metabolism. Next here, we have high-density lipoproteins, also known as our HDL. So these are loosely packed chylomicron-containing fats that is able to absorb fats and fat remnants in the periphery and is thought to have a protective effect because it decreases the development of coronary artery disease. So later on, we will discuss why. And then next here, we have an enzyme. It is known as the hydroxymethylglutaryl coenzyme A reductase, and it regulates the last step in the cellular cholesterol synthesis. Next to the enzyme, we have hyperlipidemia. It is the increase of lipid levels in our blood, and it is associated with the development of coronary artery disease. Next slide, please. Next, we have here, if we have high-density lipoproteins, then we also have low-density lipoproteins, or our LDL. These are tightly packed fats that are thought to contribute to the development of CAD when remnants left over of the LDL are processed in the arterial lining. And then we have metabolic syndrome. So what is metabolic syndrome? These are actually a collection of factors that increase the incidence of coronary artery disease. And for our risk factors, these are factors that have been identified to increase the risk of the development of a disease. And in terms of coronary artery disease, the risk factors include genetic predisposition, gender, age, high-fat diet, sedentary lifestyle, gout, hypertension, diabetes, and estrogen deficiency. Okay, so we have now unlocked the key terms for this chapter. So before proceeding, I know we have already discussed about lipids last school year, but I'd like us all first to have a review of what lipids are. So next slide, please. Okay, so lipids, these are also known as our fats and our oil. So this is an organic compound found in living organisms that is insoluble or sparingly soluble in water, or basically in those polar solvents but soluble in non-polar solvents. So we have to take note of this because since a lipid is non-soluble in polar solvents, then it is also not soluble in our blood. So why do we need lipids? What are its functions in our body? So we have here, we use it for energy storage. We use it for our membranes. That is very important. We have our cholesterol here. We also use this for emulsification. We also use this in our hormones, which serves as our messenger, and also for protective coating. So that is for our lipids. Let us now move on to the next slide. Okay, so coronary artery disease, which was discussed in the previous chapter. So in this chapter, we will discuss about drugs that will lower the levels of cholesterol and various lipids in our body. And this is what we know as our anti-hyperlipidemic agents that is used to treat hyperlipidemia. So why is there a need to lower down the cholesterol or to lower down the lipids in our body? What is its implication to the development of coronary artery disease? So really, we need cholesterol and lipids in our body. It is very important to maintain the normal functioning of our body. But when there is an excess of cholesterol or lipids in our blood vessels, then it builds up, or it builds up in our blood vessels, which then injure our blood vessels. It causes inflammatory reactions, and then it leads to the further development of atheromas, which eventually leads to coronary artery disease. So I will not dig deep into that because that has already been discussed. I'd also like to add, we have here in the last sentence of our paragraph, it says that in recent studies, it shows that those atheromas that are more lipid filled, they become to be more softer than those that are not that are less that have less lipids. So when these atheromas are more lipid filled, they are soft and they tend to rupture. They tend to have a higher risk of rupturing, which will cause blockage in our blood vessels. Meanwhile, if more stable ang atong atheromas, meaning it is less lipid filled, then it is less likely to cause rupture, which will have lesser chances of causing blockage in our blood vessels. So that is for the relationship between the coronary artery disease and, of course, the lipid levels in our body. So let us move on to the next slide. So we have here our metabolic syndrome. So when we say metabolic syndrome, these are the factors that contribute to the development of coronary artery disease. And our lipid levels also play a great role in our metabolic syndrome. So what is the factors under metabolic syndrome? We have here insulin resistance, abdominal obesity, lipid abnormalities, hypertension, pro-inflammatory state, and pro-thrombotic state. So if you want to know how to assess these, we have here the significant values in the second column. So I just want you all to read on those so we can proceed to the next slide. Okay, so in the next slide, we will talk about risk factors. So although evidences show that those people with higher lipid levels in their body is more likely to develop coronary artery disease, there are also patients na makadevelop of coronary artery disease bisan ang ilahang cholesterol levels or ang lipid levels sa ilang body is normal ra. Why? Because there are other risk factors, and examples of those risk factors are our metabolic syndromes, the factors under our metabolic syndrome, and then we have here in the table. So our risk factors, we can divide these into two categories, and that we will see in the next slide. Okay, so we can divide our risk factors into two. We have the unmodifiable risk factors and the modifiable risk factors. So when we say modifiable, of course, from the term itself, modifiable, meaning we can still do something about it. We can still modify it. Dapat tayo mahimo or pwede pa na natong makontrol. But when we say unmodifiable, meaning wala na jud tayo mahimo ana, naana jud na siya. So we have our unmodifiable risk factors. Of course, if genetic ang na coronary disease in yung family, wala na tayo mahimo ana. We have also the age. Coronary artery disease increases with age, and of course gender. So we will discuss later on which gender has a protective
What about gender dito? Sige. Does it
yes sir,
increase the risk and gender?
Women have a protective hormone.
Gender?
Women, sir, have a protective hormone against the formation of atheromas. So I will discuss that later on po, sir.
Very
Okay.
good.
So
Continue.
okay, so for our modifiable risk factors, we also have gout. So increased uric acid levels increases the risk also for injuring our blood vessels. And we also have cigarette smoking because nicotine causes vasoconstriction, and sedentary lifestyle, of course. High stress levels also contribute to the development of atheromas, hypertension, obesity, diabetes, and others. So those are our risk factors. Now let us move on. So, if we have these risk factors, how do we treat coronary artery disease? So, at present, there is still no known exact cause, Jude, as to why we develop coronary artery disease. But aside from drug therapy, of course, overall treatment and prevention as well involves the manipulation of a number of risk factors. So, of course, because we have modifiable risk factors, meaning there are still things that we can do to prevent or to cure, or I mean to treat coronary artery disease. And here is, we can find this here in the table. So, of course, for our first column, we really can do nothing about it. Those are unmodifiable. For our modifiable risks, we can do exercise, have low fat diet, quit smoking. We also need to do weight loss activity. We need to manage our stress. If we have antibiotic diseases, or I mean bacterial infection, I mean, we can go to our doctor to have antibiotic treatment. We also need to control our blood glucose, our blood pressure, and our uric acid levels. And of course, in women, we can do hormone replacement therapy for the first few years of menopause. So later on, I will discuss about the gender variations, and we will know why hormone replacement therapy is included in this table. Okay, so next slide, please. Okay, so since today we will be talking about lipids, let us get to know our lipids more. So how do we take in lipids, and how do we process lipids in our body? So first, we have here in number 1, we take in lipids as dietary fats. And then they enter our stomach. In the stomach here, the lipids are broken down into fatty acids and cholesterols and lipids. And then this will enter our duodenum, or the small intestine. And the presence of these substances in our small intestine will then stimulate our gallbladder to contract. And the contraction of the gallbladder will lead to the release of bile into the small intestine. So, unsam di ay purpose aning bile sa atong intestine? So, we have discussed earlier in our glossary of terms that bile acts as emulsifier. So, when we say emulsifier, it acts like detergents, or it breaks down fats into components that is that can be absorbed by our small intestine. So after number 4, we have here in number 5, the bile, after it did its thing, it will go back into the liver to be recycled. And then, of course, katong mga products nga na break down sa atong bile, mahimo to siyang micelles. And this micelles, in number 6b, will be absorbed into the small intestine walls, which will be packaged as chylomicrons. So nga namang kinahanglan man taog chylomicrons, di ba? We have discussed earlier that lipid is non-soluble or sparingly soluble in polar substances. So meaning, ang lipid, dili siya ka-circulate sa atong body because our blood is polar, meaning dili siya soluble sa atong blood. That's why we need these chylomicrons to carry the lipids for us. So what happens next? The chylomicrons will be absorbed into our lymphatic system, and then it will be delivered to the heart. So here in the heart, the lipids through the chylomicrons will be pumped into our circulatory system to reach our periphery. And what happens next? It's either we use it as energy, we store it as fat, or if there is excess of these, this can develop into atheromas. What will happen after these fats develop into atheromas? This will injure our vessels, this will inflame our vessels, and of course, this will become remnants. So next, the liver processes the fats to LDLs and HDLs that will enter the circulation and reach the periphery. So unsa man ining LDLs and HDLs? So let's move on to the next slide for us to know. So LDLs and HDLs, I believe I have already defined this earlier, but I All right, now we will dig deep into this. So LDLs. So LDLs enter the circulation as tightly packed cholesterol, triglycerides, and lipids carried by proteins in the circulatory system to be broken down, either for energy or for storage. So the breaking down of this LDL will leave remnants, or kung ato pang in simpler terms, siya basura after nimo na break down ang LDL, and this will be left in our blood vessel. So this remnant needs to be returned into our liver para dili siya mo pile up sa atong blood vessels. That is why if mas daghan ang atong LDL, mas daghan ang remnants nga mahimo, and this remnants is thought to cause an inflammatory process in our blood vessels, which we know can contribute to the development of coronary artery disease. That is why kanang cholesterols associated with our LDLs are also known as our bad cholesterols. Okay, so how about our high-density lipoproteins? So unlike the LDLs, high-density lipoproteins enter our body or our circulation as loosely packed lipids. So dili siya tightly packed. So it is used for energy and for the pickup of remnants left in the periphery from LDL breakdown, which provides a protective role, for it cleans up the blood vessels. So basically, if we see it, ang atong LDLs mo oy mag-leave og basura sa atong ang blood vessels, while our HDLs mo oy maglimpyo or magkuha ana nga mga remnants. That is why it is good for us. So HDLs increase during exercise and in response to estrogen. So diba, we have discussed earlier that one thing that we could do in our modifiable risk factors is to perform exercise. So this actually explains why. This is because our HDLs, which is also known as our good cholesterol, kay of course mo pick up man siya og remnants of fat sa atong blood vessels, kay mo increase siya during exercise. That is why exercise is helpful for us. And aside from that, in women, we have the hormone estrogen, and this provides actually women a protection against the development of atheromas leading to CAD, because our HDLs also increase in response to estrogen. So that is all for our LDLs and HDLs. Let us move on to the next slide. So what actually is cholesterol? So again, cholesterol, we need this in our normal body functions because it is the base unit of our steroid hormones and the basic unit for the formation and maintenance of our cell membrane. So where do we get this cholesterol? We have discussed earlier that we get this from our dietary intake. We take cholesterol as dietary fats. But what if there are circumstances that we do not get enough cholesterol that our body needs? Actually, our body is prepared to produce the cholesterol to ensure that the body gets the enough cholesterol it needs to sustain normal body functions. And why is our cells able to do that? Because we have this enzyme called hydroxymethylbutyryl coenzyme A reductase. So take note of that because it is very important later on when we discuss about the drugs. So what does this enzyme do? It regulates the early rate limiting step in the cellular synthesis of cholesterol. So simply ra, if wala ka ana nga enzyme, dili ka synthesize of cholesterol ang imong cells. So that is very important. So what is the relationship of our dietary intake to the cellular synthesis of cholesterol? Of course, it is inversely proportional. Kung gamay ang atong dietary intake, dili kaigo nga mo support sa atong normal body functions, then mas daghan ang ato ang cellular synthesis of cholesterol. Also, if daghan na ang ato ang dietary intake that is enough to suffice the needs of our body, then mogamay na pod ang atong cellular synthesis of cholesterol. So that is all for cholesterol. Now let us move on to the next slide. Now we will discuss about hyperlipidemias. So hyperlipidemias is characterized by the increase of lipid levels, which can be caused by excessive intake of dietary fats or from genetic alterations in fat metabolism. So we have here in our table 47.3, which was we got this from the book. This table gives standard guidelines for lipid levels. So these are the normal values. I will not read all of this. I just hope that you guys read through this. So aside from dietary intake, of course, there are also cultural and genetic variations with regards to the lipid levels in our body. So let us know about these variations in the next slide. Okay, so we have here cultural variations. So cultural variations in key lipid parameters include the following. So for our cholesterol levels, whites have higher cholesterol levels than African Americans and Native Americans. For high density lipoprotein levels, African Americans and Asian Americans have higher of these levels than whites, as well as Mexican Americans. And also for our low density lipoprotein levels, African Americans have lower levels of our LDLs than our white Americans. And lastly, for our HDL cholesterol ratio, African Americans have lower lipid levels of these than whites. So just take note of those, kay basin later on when we practice nursing, we will have patients from also different cultures and different parts of the country. So we also have to know about those. Now, let us move on to the genetic variation. So actually, we have been talking about this ganina pa jud, that we also know that our HDL increase in response to estrogen. So that is why naatay genetic variation, because this increase of HDLs in response to estrogen give women a protective feature against CAD. Why? Because madaghan ang atong HDLs, mas budaghan ang molimpyo sa remnants sa atong blood vessels. However, if magmenopause na ang women, the loss of estrogen supply or decrease in estrogen supply pave way to the rapid formation of atheromas and the development of CAD. Sorry for the typo. So before, they studied that, yes, what if we do hormonal replacement therapy kay para na radya po'y supply of estrogen ang lawas sa bayi. So studies reveal that before, this actually helped in decreasing the risk of CAD and myocardial infarction. However, as the studies continued, it revealed that after 5 years of HRT, myocardial infarction and stroke incidence rose sharply among women. So that is why HRD is still not recommended as means of reducing the risk of heart disease or stroke in women of menopausal age. Although we can still use it as treatment for severe menopausal symptoms in women, but only for the first few years. So those are our cultural and our genetic variations. Next slide, please. So now that we already know what hyperlipidemia is, let us get to know the drugs or the agents that we will use to decrease the cholesterol or lipid levels in our body. So we have here our bile acid sequestrants, our HMG coenzyme A reductase inhibitors, our cholesterol absorption inhibitor, and we have our other lipid lowering agents, which includes our fibrates and our vitamin B3 or our niacin. So let us move on. So before we, next slide, please. So before we discuss about those drugs, let us first know what are the drug therapy across the lifespan. Okay, so I'd just like you all to read on these because these are all self-explanatory. So these are for the children, for adults, and next slide. We have for the older adults. So let us now move on with our first class of drugs. Next slide, please. So first here we have our bile acid sequestrants. So what does the bile acid sequestrants do? So these drugs bind with the bile acids in the intestine to form an insoluble complex excreted by the body through the feces. This prevents free absorption of fats and it increases fat excretion. So nga naman di ay if mo bind siya sa bile acid sa atong intestine, nga naman mo increase siya sa absorption sa atong fats. So we learned earlier in our fat metabolism that after the bile acids do extinct in the intestine, it will be recycled back into the liver. Now karon nga natay bile acid sequestrants, dili na mabalik tong bile acid sa livers because ni bind na siya sa atong bile acid sequestrants which ato nang ikalibang. So what will the liver do? The liver will make more bile acids, and in order for the liver to do that, the liver needs to make use of more cholesterol. So, unsa may gamiton sa atong liver nga more cholesterol? The liver will make use of our cholesterol or of our hepatic intracellular cholesterol or katong naa sa liver na nato nga cholesterol. And in order to replenish nga katong cholesterol nga atong na-use, the liver will increase its absorption of cholesterol-containing LDL segments from our circulatory system. So as a result, there is an increase in the cholesterol and LDL levels absorption and increase atong fat excretion because katong ato ang bile acid na dapat mo balik sa liver ato namang gi-excrete to the feces. Okay? So bile acid sequestrants are also used in patients with primary hypercholesterolemia as an adjunct to diet and exercise. Also, we can use our bile acid sequestrants to treat pruritus. So what is pruritus? Pruritus is skin itching. So pruritus that is associated to partial biliary obstruction. This happens when bile salts accumulate in our blood. Why? Because there is again a partial obstruction in the tube that connects our liver to our gallbladder and to our intestine. So dili jud kaadto ang tanang bile acid atong intestine mo nang mag-accumulate siya sa blood causing pruritus. So bile acid sequestrants can be also used to treat that. So let's go on to our pharmacokinetics. We have this is not absorbed systematically, of course, because it's work in our small intestine and it is excreted directly through the feces. So for our cholestyramine, it is a powder form that should be mixed with liquids and be taken up to 6 times a day. For our cholesterol, it is available in both powder and tablet form and should be taken only 4 times. And for our cholesterol, it is available in tablet form that should be taken twice a day. So let us move on to the next slide. So for our contraindications and caution, so I'd like you all to just read on those. But there's one thing I'd like to highlight also. Although bile acid sequestrants can be used to treat pruritus related to partial biliary obstruction, it cannot be used to. It is contraindicated to complete biliary obstruction. Why? Because when there is complete biliary obstruction, wala na dyan bile acids nga makaadtuan na sa atong small intestine. So unsa pa may bindan sa atong bile acid sequestrant, so wala na. So it is contraindicated for.
Okay. Ana niya, yung naroon mo pag-follow sa type of reporting, ipabasa lang sa inyo mga classmates, all the rest. Pero you emphasize on what needs to be emphasized. Okay? Sige, continue.
Okay, thank you, Doc. So we have here the adverse effects. Of course, the adverse effects related to the change in cholesterol levels, headache, anxiety, fatigue, and drowsiness. We also have our GI irritation, of course, because it works in our small intestine. So we have here constipation and also increased bleeding related to decreased absorption of vitamin K and consequent decreased production of clotting factors. We also have our vitamin A and vitamin D deficiencies, rash, muscle aches, and pains. So nga naman nga naay deficiency sa atong vitamin A and our vitamin D. So actually, dili ra vitamin A and D ang naay deficiencies. All our fat-soluble vitamins naay effect ang ato ang bile acid sequestrants because, again, mubay magud siya og fat sa ato ang intestines. Then, iyang ikalabang, so naay decrease jud og absorption sa ato ang vitamin A, K, E, D, which are all fat-soluble. So let us move on to the next slide. So, clinically important drug-drug interaction. So, again, na-adjoy malabsorption sa atong fat-soluble vitamins. So, there is also decreased absorption of our thiazide diuretics, digoxin, warfarin, thyroid hormones, and corticosteroids. But, makatake ra dyan ani nga drugs, but it should be taken 1 hour before or 4 to 6 hours after bile acid sequestration. So, next slide, please.
Okay, I'd just like to re-emphasize the importance of why you will have all those deficiencies when you take bile acid sequestrants. Because as the name implies, it is a bile acid binding resin which helps to bind the cholesterol to the bile and to be excreted. Again, it promotes excretion of your cholesterol. Then with excretion of your cholesterol, just imagine, you need those fats also for the absorption of like your fat-soluble vitamins, your other vitamins, which needs fat. Now, if imong i-decrease ang absorption sa fats, so ma-decrease mo ang absorption itong magkinahanglan sa fats. There are also drugs that needs your fat. That's why may drug nga drink with a fatty meal. Now, those drugs also have less absorption if you use your bile acid sequestrants. This is also called your bile acid binding resins or bile sequestrants. Pareho na sila if you hear SATs. Okay? Again, it helps to eliminate the fat. Kaya mang i-bind yung kalibang ra ninyo. Okay? Sige, continue.
Okay, so thank you for that, Doc. So we have here a table summarizing the drugs under bile acid sequestrants, their usual dosage, and their usual indication. So just read on that. Next slide, please. So we have here very important nursing considerations. So just read on those. You can take a screenshot if you want, or I can send a copy later. Okay, next slide. Okay, so let us move on to the second class of drugs that we will be discussing in this chapter. We have our HMG coenzyme A reductase inhibitor. So we have discussed about what this enzyme is all about. So again, this enzyme, we need this in the cellular synthesis of our cholesterol. So what does this drug do? It inhibits the HMG coenzyme A reductase, and that enzyme is involved in the rate-limiting step in the cellular synthesis of cholesterol. So syempre, if ma-inhibit na nato ni nga enzyme, dili na jud kahimo og cholesterol ang atong cells. So if this enzyme is blocked, serum cholesterol and LDL levels decrease. Why nga namang mo-decrease ang atong LDL levels? Because when our cells can no longer synthesize cholesterol, they absorb more LDLs from the bloodstream for the processing of cholesterol. And also, in this alteration of fat metabolism, mo increase pod ang atong high density lipoproteins, which is our good cholesterol. So these drugs are chemical modifications of compounds produced by fungi. And also, this is very important, these groups of drugs are frequently referred to as statins. So later on, when we see the drugs under this class, we can see that most of the drugs or all of the drugs end in statin. So these drugs also undergo a marked first pass effect, hence most of their effects are seen in the liver. So this is indicated for the treatment of increased cholesterol and LDL levels unresponsive to dietary restrictions alone. These drugs are used as adjuncts with diet and exercise. Next slide, please. So this is the table showing the drugs under HMG coenzyme A reductase inhibitor. So as you can see, nag-end na sila tanan og statin. So dili ra lisod nato i-remember what are the drugs under this class. Next slide. Yes, we also have pravastatin, rosuvastatin, and simvastatin. Okay, next slide. Okay, so our pharmacokinetics, just read on those, but I'd like to emphasize that these drugs are most effective when we take these drugs at night. Why? Because the liver mostly processes lipids at night than at daytime. So mas effective siya if gabi na to imnon. And this is also contraindicated to any allergy to the drug, to patients with liver disease, pregnancy, and also to those with renal impairment.
Okay, ayaw kalimtin ha to be taken at night na ha, because it is your problem as nurses. Unsaon na paghatag sa inyong pasyente. Ang kamo po'y maghatag og instruction sa patient on discharge kung when ang time pag-take sa medication. So, importante na ninyo as nurses. Continue.
Okay, thank you, Doc. So next slide, please. Okay, here, so we have the adverse effects. We have the adverse effects in our GI, in our CNS, and also there have been records of acute liver failure for atorvastatin and fluvastatin, and this drug can also has an adverse effects of rhabdomyolysis. So what is rhabdomyolysis? It is the muscle breakdown or muscle death. And for simvastatin, there have also been records of patients having cardiovascular disease. Okay, next slide, please. So for our clinically important drug-drug interaction, so we have erythromycin, cyclosporin, gemfibrozil, niacin.
More important there. Sige.
Okay.
Wala
Next slide.
wala ginay gibutang dito, should not be, never use, nana. So use with caution lagi hapon in almost any other drug. Continue.
Sige, next slide, please. So we have here for our nursing considerations. I hope you guys read on those. And then next slide back. And then for the implementation and evaluation. Next slide, please. Now let's move on to the third class of drugs. We have our cholesterol absorption inhibitors. So we have only one drug under this class. We have our ezetimibe. And next slide, please. So what does this drug do? So it decreased dietary cholesterol absorption from the small intestine. This drug works on the brush border of our small intestines. So its pharmacokinetics, mauna siya. Actually, currently, because of an enhanced study also, there have been a question on the drug safety of this drug, but studies are still ongoing. So next slide, please. So for the contraindications, of course, allergy used with caution in pregnant or lactating women. And for these are the adverse effects. I'd like you all to please read on those. And then next slide. So these are the clinically important drug-drug interactions. So if they use this with cholestyramine, fenofibrate, gemfibrozil, increased risk of elevated serum levels of ezetimibe. And then the next, we have increased risk of toxicity if cyclosporine is taken with it. If fibrate, increased risk of cholithiasis. So cholithiasis, these are also known as our gallstones. And of course, for warfarin, increased levels of warfarin. So next slide, please. So we have our nursing considerations. We have the assessment, diagnosis, implementation, and evaluation all in one table. So you can take a screenshot and read on those. Next slide. Next here, we have our other lipid lowering agents. So we have here our fibrates. So general mechanism of action of our fibrates, guys. Sorry, I was not able to put this in this slide, but na siya sa next slide. These are our PPAR alpha agonist. So what does PPAR mean? So PPAR means peroxisome proliferator activated receptor. So basically rajon ang himuon ani niya is it increase the lysis of our fats. So hilison niya atong fats. That is why makatabang siya pag lower sa ato ang lipid levels. So under fibrates we have fenofibrate. It inhibits triglyceride synthesis in the liver, reducing LDL levels, increasing uric acid secretion, and stimulating triglyceride breakdown. And for our gemfibrozil, it inhibits peripheral breakdown of lipids. It reduces the production of triglycerides and LDLs, and it increases HDL concentrations. And take note in gemfibrozil, it should not be combined with statins because of increased risk of rhabdomyolysis. Okay, so next slide.
Okay, wait.
Sorry, ayaw pa niya.
Fibrates, with regard to your fenofibrates, what is another important thing here is tanawan na yung indication. It's more on triglycerides. So when you take your blood lipids, when you take your lipids, lipid panel ninyo, naman na yung mga triglyceride, LDL, HDL, VLDL, ano na kabutang dito. If your triglyceride is that high, by the way, triglycerides most commonly is increased with rice eaters. If you are a voracious rice eater, most likely, if your cholesterol increases, most likely it's more on your triglyceride. So if it is more on triglycerides ang nisaka ninyo and less of those other types of cholesterol, this is the best drug for you, your fibrates, your fenofibrates. Again, because the main mechanism of action is it decreases the synthesis of your triglycerides. Okay, so next.
Okay, so thank you, Doc. And then for the last, under fibrates, we have our fenofibrate acid. So, ano siya akong giingon ganina, guys, nga mechanism of action sa atong fibrates. This is the peroxisome proliferator receptor alpha activator.
Or it's an agonist, activator or an agonist. It's a PPAR alpha agonist. Okay. So, yeah.
So,
PPAR alpha does, diba?
Yes, sir, lysis of fats. Okay, so what does the fenofibric acid do? So this drug causes increased breakdown of lipids, elimination of triglyceride-rich particles from the plasma, and reduction in the production of an enzyme that naturally inhibits lipid breakdown. Okay, so next slide. So this is contraindicated for patients with renal impairment, and caution for patients. This is contraindicated for those patients with severe renal impairment, but is only cautioned for patients na naapay renal impairment. This is also its adverse effects and clinically important drug-drug interaction. Okay, so next slide. Next let's move on to our vitamin B3 or niacin. So actually,
Very important. Sige.
sige. So actually, our vitamin B3 or our niacin is the most effective agent when we want to increase our HDL or our good cholesterol. So what does our vitamin B3 do? It inhibits the release of free fatty acids from our adipose tissues, thus increasing the rate of triglyceride removal from plasma and reducing LDL and triglyceride levels and increasing HDL levels. So take note, ang atong vitamin B3 jud mo na pinaka-effective nga agent if we want to increase our HDLs. So we have here its initial effect and its maximum effect. Its maximum effect is 3 to 5 weeks. Its adverse effects, clinically important drug-drug interaction. So it is not, we should take this with caution if we are to take bile acid sequestrants because of the increased effect. And for the administration, again, it should be given at bedtime for maximum use and must be given 4 to 6 hours after bile acid sequestrants. Also, our vitamin B3 or our niacin is the only agent that reduces our lipoprotein A. So that is for vitamin B3. Next slide, please. So combination therapy. So we use combination therapy when a patient does not respond to strict dietary modification, exercise, lifestyle changes, or when the patient does not respond to using one lipid-lowering agent only. So basically, combination therapy is using combination of drugs. So we have here Advicor. It is a fixed combination of extended-release niacin and lovastatin. So what it does is it reduces the risk of atherosclerosis in patients with multiple risk factors. So take note, guys, if you want to use Advicor, the drug is intended as initial therapy and it should only be used if the patient has already been stabilized on lovastatin and the extended release niacin and is found to tolerate those two drugs. So before ninyo magamit na ang combination therapy. Next is our omega-3 acid ethyl ester. So this is the combination of omega-3 fatty acids and an activator that inhibits liver enzyme systems. So it is approved to lower triglyceride in adults with very high triglyceride levels. It should be combined with appropriate diet and exercise, and it is not recommended for pregnant or lactating women. So there is a substantial research that has shown to support the effects of this drug, unlike those research on the over-the-counter fish oil products. So mas naani siya evidence nga makatabang makasupport sa iyang efficacy kaysa atong mga fish oil products nga atong mapalit over the counter, which does not have any support with regards to its efficacy.
Hold on. Dali ha. Tanawa ra gud ang iya nga slide. Nara ko na-notice sa slide ha. Murag ang iya nga black nga letters nasa likod dayong ang iya nga red nasa front. Naka-notice pud mo? Or ako lang? Mura bitaw nasa likod ang black dayong nasa tuwangan ang red. Murang may pagkabutang ba? Mura siya glass nga ang ilalom dito gisulat ang black dayong sa ibabaw dito gisulat, ibabaw sa glass dito gisulat ang red. Yun na yun nakita sa yung slide, dili. Ako ra. Dili, Dok.
Dili, Doc.
Dili?
No.
Kasi sa quality lang.
Oy. Sa ako ra di ba iyang effect? Ikay gahimo ani sa banal?
Christian Tinapaw, Doc.
Okay na. Moy akong manotice sa slide. Nice mo siya tanawon ba kay murag 3D. Whatever. Sige, next slide.
Yes, Doc. So si Christian Tinapaw, gugit anak, Doc.
Sige, next.
Okay. So next slide. So we have here combination therapy for treating coronary artery disease. So first one, we have our CAD duet. It is a combination of 5 or 10 milligrams amlodipine and 10, 20, 40, or 80 milligrams of atorvastatin.
That combination. Sige, go.
So we need to take note that before the patient should undergo this combination
Never
therapy.
mind the combination. It is not our problem. So ang katong basic drugs lang. Sige.
Okay, sir. Okay, sir. So next we have our Vitarin. It is a combination of ezetimibe and simvastatin. It is approved to help lower lipid levels in
Never mind
patients.
lagi. Never
I'm
mind.
sorry,
Just
sir.
mention those combinations.
Okay.
Dayong, it is not our problem. Okay.
Okay. Next
Kung
is
kabalo mo sa
our
basic drug lang, maura na. Kanang i-combine siya, yes, you can do anything. Sige, continue.
and then lastly we have our Simcor. Okay. So next slide, please. So here we have our future therapies. So at present, new drugs are being investigated with hopes of having drugs that will cut off.
Okay, so never mind that. As long as you know this is a possibility in the future, kanang inyong marijuana. Sige, next slide.
Okay, so we have here so the table shows the effects of blocking our endocannabinoids, so just read on those. And then next here we have our rimonabant. So rimonabant is an endocannabinoid blocker that has been used in Europe as a weight loss agent. So this drug shows to reduce weight and abdominal adiposity and improve lipid profiles while increasing insulin sensitivity and reduce pro-inflammatory and pro-thrombotic markers. However, in 2008, preliminary showed no change in atherosclerosis and disease progression. So safety of the drug became questionable due to significant CNS changes. So at present, there are still lots of studies about future therapies for the treatment of atheromas and CAD. So that is all for my report. I hope you guys learned from this discussion. Thank you very much.
Okay, we'll proceed with the next. We have two more, right? Two more chapters. We still have a lot of time. We still have an hour. Now, with regards to this drug affecting blood coagulation, you just have to classify this drug as direct or indirect thrombin inhibitors. First, you're going to discuss the steps in your blood coagulation. Sige, go.
So good morning, everyone. Good morning, Doc. I'm Cantaleza, and I will report about the drug.
Dili madungog yung tingog inday.
Ayala. Hello?
Dili madungog kayo. Kusga-kusga, ipadol imong baba sa mic.
Kana, Doc. Hello?
Baling inayag yun.
Hello? Good morning.
Kana, sige.
So today we will tackle about the chapter 48, drugs affecting blood coagulation. So when we say blood coagulation, it is a process of forming a clot or thrombus in order to prevent excess loss of blood from the body. So the key terms are, next. So anticoagulants, these are drugs that block or inhibit any step of the coagulation process, preventing or slowing clot formation. Antiplatelet agents, these are drugs that interfere with the aggregation or clumping of platelets to form the platelet plug. Clotting factors, substances formed in the liver, mainly requiring vitamin K that reacts in a cascading sequence to cause the formation of thrombin from prothrombin. Thrombin then breaks down fibrin threads from fibrinogen to form a clot. Coagulation, this is the process of blood changing from a fluid state to a solid state to plug injuries to the vascular system. Next. Extrinsic pathway. This is a cascade of clotting factors in blood that has escaped the vascular system to form a clot on the outside of the injured vessel. Hageman factor, first factor activated when a blood vessel or cell is injured. Starts the cascading reaction of the clotting factors, activates the conversion of plasminogen to plasmin to dissolve clots, and activates the Keenan system responsible for activation of the inflammatory response. And hemorrhagic disorders, this is disorders characterized by a lack of clot-forming substances, leading to states of excessive bleeding. Next, hemostatic agents. These are drugs that stop blood loss, usually by blocking the plasminogen mechanism and preventing clot dissolution. Intrinsic pathway, cascade of clotting factors leading to the formation of a clot within an injured vessel. Plasminogen, it is a natural clot dissolving system converted to plasmin by many substances to dissolve clots that have formed and to maintain the patency of injured vessels. And platelet aggregation, property of platelets to adhere to an injured surface and then attract other platelets which clump together or aggregate at the area, plugging up an injury to the vascular system. Next. Thromboembolic disorders. Disorders characterized by the formation of clots or thrombi on injured blood vessels with potential breaking of the clot to form emboli that can travel to smaller vessels where they become lodged and occlude to vessels. Thrombolytic agents. These are drugs that lyse or break down a clot that has formed, and these drugs activate the plasminogen mechanism to dissolve fibrin threads. So, we already tackled the meaning of blood coagulation. This is a process of changing from a fluid state to a solid state to plug injuries to the vascular system. And excuse me, the vascular system must maintain an intricate balance between the tendency to clot or form a solid state, called coagulation, and the need to unclot or reserve coagulation to keep the vessels open and the blood flowing. Drugs that affect blood coagulation work at various steps in the blood clotting and clot dissolving process to restore the balance that is needed to maintain the cardiovascular system. Next. So the drug therapy across the lifespan is on the book, so kindly read na lang. So next. Next. So here is the clotting process. So clotting process involves vasoconstriction, platelet clumping or aggregation, a cascade of clotting factors produced in the liver into insoluble fibrin threads. So, and when a clot is formed, plasmin acts to break it down. So it was mentioned on the key terms. So next. So we already know that vasoconstriction is the narrowing of the blood vessels, and this is the first reaction to a blood vessel injury. And in this diagram, you can see the process of blood coagulation. And on the right side, you can say that blood coagulation is usually a result of both intrinsic and its extrinsic pathway. So next. Next. Next, palihog. Hello. Ay, katupang palihog ko sa platelet aggregation. Before. Di pa before. Kana. Thank you. So, platelet aggregation. Injury to a blood vessel exposes blood to the collagen and other substances under the endothelial lining of the vessel. So the circulating blood will attach or adhere to the injured site, and then once they've done it, when platelets stick together, they release adenosine diphosphate, serotonin, and other chemical substances that attract other platelets, leading them to cluster and clump together to remain as well. In many injuries, the combination of vasoconstriction and platelet aggregation is enough to seal off the injury. So this is ADP. It is a precursor of the prostaglandins, from which thromboxane E2 is formed, and thromboxane E2 causes local vasoconstriction and further platelet aggregation and adhesion. Next. So intrinsic pathway, this is a cascading series of coagulant substances that can be activated only when a Hageman factor can encounter or expose to a collagen of the injured blood vessels. So next. So extrinsic pathway, While the coagulation process is going on inside the blood vessel via the intrinsic pathway, the extrinsic pathway causes the blood that has leaked out of the vascular system and into the surrounding tissues to clot. Injured cells release a substance called tissue thromboplastin, which activates clotting factors in the blood and starts the clotting cascade to form a clot on the outside of the blood vessels. So next is the diagram. So the difference between the intrinsic pathway and the extrinsic pathway is that intrinsic pathway starts when there is a trauma in blood or a blood vessel injury. And in the extrinsic pathway, it starts when there is a vascular tissue trauma or a tissue injury. So in intrinsic pathway, it begins with blood vessel injury, no? And then when factor 12 contacts with when factor 12 contacts with exposed collagen, it activates and catalyzes the activation of factor 11. So kanang paubos. And then activated factor 11 then activates the factor 9 or the Christmas factor. And then
Dali lang ha. Ayaw lang kayo go into the details ana niya in that.
sige.
So, skip
So,
lang na
last-
siya.
Sige, thank you, Doc.
Ana lang yung dapat pinabalaman ha. Exposure of collagen will trigger all these things. So, kung naay nasama din yung ugat ba, these are even the smaller blood vessel as long as this is the blood vessel that is injured. This cascade of events will follow. First, of course, with the injuries sa inyong blood vessel wall, yun ay ma-release nga collagen. And this will start everything na. Okay? So, this clot resolution is drug naman din yung ipang-mention na this one. Okay, let's go back sa imong mechanism again. The first thing that will happen with injury to blood vessel is there will be immediate constriction of the blood vessel. That is not part of the clotting process. Mo-constrict ka imong blood vessel, that is still not part of your clotting process, ha? Okay, because that is the reflex reaction of your blood vessel to injury. Your blood vessel will hope to decrease the bleeding. Kaya kung mo-constrict siya, siyempre mo gamay ang agianan, gamay ang mo-flow nga dugo, di ba? So mo-decrease yun ang flow sa blood, sa bleeding ni mo, kung mo-constrict ang blood vessel. That is the initial reaction of the blood vessel. Now, after the immediate constriction of the blood vessel, there will be your clotting mechanism na. There are 4 stages of the clotting mechanism. First is the formation, the formation of your platelet plug. Again, katong gi-state niya nga daghan kayong mga kutso-kutso dito, from injury to the exposure of your collagen. Yung mga platelet ha, once nga ma-injure magod yung blood vessel wall, di ba rough ang surface, kung with injury rough ang surface ang blood vessel wall, kaya tungod rough ang surface ang mga platelet mo adhere sa rough na surface, normal na siya. Kaya yung hitsura sa imong platelet mong good is irregular ang iyang wall, so pwede siyang masangit sa imong rough na surface. So again, pag sangit sa rough na surface mo, daghan siya dito mga accumulate siya, there will be platelet plug formation. So ma-plug ang buslot sa imong blood vessel wall because of the platelets accumulation. So that is the first step, that is the platelet plug formation. After which, there will be activation of your prothrombin. Okay? So prothrombin will be activated. It will become thrombin. Thrombin is a soft clot. Soft clot pa na siya, dili pa na siya stable. Again, thrombin formation is the next after activation of your prothrombin. Again, so first step, platelet plug formation. Second step is thrombin formation. And the third step will be fibrin formation. Now, how is the fibrin formed? The fibrin is formed from your fibrinogen. Kung nagay gen that is inactive pa, like angiotensinogen, we have discussed that, inactive na. Your fibrinogen, inactive. Your prothrombin, pro meaning before, so it is still not active. So prothrombin will become thrombin, fibrinogen will become fibrin. So what would catalyze the formation of fibrin from fibrinogen? It is your thrombin. Okay, so again, platelet injury, vessel injury, then mo adhere dito sa rough na surface sa imong mga platelets, mudagan siya, there will be plugging of the injured vessel wall. So di na siya mo padayon og bleed kay na plug naman siya sa imong mga platelet accumulation. After which there will be activation of your prothrombin to become thrombin. Now this product, this thrombin, will now catalyze the activation of your fibrinogen to become fibrin. Your fibrin is already the solid clot. So enough na siya. There will be fibrin formation. But, ana ni metabo. The third step na siya, ana ni metabo. With fibrin formation na siya clot, di ba, gasampong siya sa imong mga vessel wall, sumugamay ang agianan sa imong vessel wall. Nakuha ninyo, ang lumen niya mugamay.